talking about NIV in ARDS.
Thank you very much, and thank you very much. I'd like to thank the Scientific Commission for inviting me here to talk about the NIV in ARDS. So, you know, we all have some conflicts, but I have no conflict of interest related to this presentation. So, NIV in ARDS, well, we can say that this is really the last frontier. So you see this rather romantic view. We could say that indeed is the most severe type of ARF. It's also a diffuse functional and structural lung injury. And there can also be the problem of ventilation assist that will be discontinued in terms of recruitment or alveolar de-recruitment. So there are very few studies. The very first one, as far as I know, is that by Rocker in 1999. And what strikes me here is the optimism of this work, where the authors are actually delighted to tell us that they managed to avoid intubation in 50% of their patients. So you see 12 patients and intubation avoided in 50% of the cases. So here we also have the work by Massimo Antonelli, published in 2007, which is, as far as I know, the study that included the most patients in ARDS treated with NIV. It's a multi-centered cohort study. And also here around 50% of success, that is no intubation, fewer nosocomial pneumonias, and less mortality. So I'll go back to it later. But here already we're underlining the patients in a situation of failure in terms of NIV in the most severe condition, and NIV was not able to improve enough the hypoxemia situation of the patients. So few studies, if we want here to go over these studies, maybe the list is not exhaustive. I might have forgotten a few. Here you see the percentage of success defined as no intubation, and here the figures is the number of patients who were included in the various studies, and you see it was just a handful of patients, just a few studies, and we can say that overall NIV in ARDS represents 50% of success. So this is the optimistic version. We could also look at the more pessimistic version, which would be 50% of failure. And because of these failures, well, we have also formulated some messages towards caution. So the very first one is this one. Antonelli, again, and CCM 2007, you see that when these patients have a successful NIV, mortality is very low. But when there is a failure of NIV in this group, even if this work took 10 years, there was still 50% of mortality in ARDS. It's significant, maybe too high. And the other message in terms of caution, here you see Damocles and his sword, and actually, NIV could worsen lung injuries. Are we sure that this ventilation is actually protective? And the third message of caution is to say, well, maybe there is a beneficial impact of NIV, but is this an actual benefit? Or basically, is this for patients in the less severe state, and are they actually ARDS patients? So, messages of caution to such a point that the French consensus on NIV in 2006 does not specify an indication of NIV in ARDS. So, caution, yes, but, because you know that for about 2 or 3 years, the ARDS family has been extended. Now we have some mild ARDS with a PF between 200 and 300, moderate and severe PF between 100 and 200, and below 100, with a PEEP always above or equal to 5 centimeters of water. And here, some experts have proposed a strategy for the management, depending on the severity of these ARDSs. And you see that for mild ARDS, we see the non-invasive ventilation that is mentioned. Wonderful. So are they right? Well, they are experts, so they are probably right. You see this work by Zahn, published in 2012, a controlled randomized study, NIV compared to oxygen, PF 225 under NIV, probably mild ARDS, 40 patients included, 20 in each group. And you see a significant difference in terms of intubation with a result that is exceptional, 95% of success in the NIV group, but even in Bordeaux, we've never reached those results, I want you to know. However, these patients have been selected very strictly. You see the number of patients included over 3 years. So NIV with patients with mild ARDS, an expert opinion, positive randomized controlled trial, everything seems to be fine. But what about moderate ARDS? So we could stop at this stage, but I think there's still some room, some opening actually, even in that subgroup of patients. So why? Because NIV is a technique that is used more and more, including for ARF with hypoxemia. So it's a technique that is used more and more, and that we know better and better. This is a technique that we probably know how to optimize, and it's also a technique that in this specific case of that we can optimize and that we have to optimize. So what are the goals of any ventilation? So I know at least 3. Improve gas exchanges and reduce hypoxemia. Management of the patient's inspiratory effort without injuring the lung. So the improvement of PO2 with NIV, we know it works. With Antonelli, 1998, the PF ratio is clearly improved. So this improvement of PO2 is due to PEEP to a large extent. If you look at this work by Erwan Lair, physiological work, 10 patients, 8 with ARDS. So you see that these patients and the inspiratory pressure maximal, constant, this is the ones for whom PEEP was the highest, that there was the most significant improvement in that ratio. So PEEP is a necessary condition. If you look at the various levels of PEEP in the literature, when it's available, it goes between 5 to 7 centimeters of water. And I think, indeed, that if you have NIV in ARDS, you should have at least 7 centimeters of water, but we can rarely go beyond 8 to 10 centimeters. It seems to be the maximum. So PEEP is a necessary condition, probably not sufficient. I'm not going to dwell on this work by Delclos on CPAP that was negative. So maybe there is inspiratory assist that is necessary. So one of the physiopathological interests of inspiratory assist is that it manages the inspiratory effort. You see here, these are the patients with the highest level of assist who see that their inspiratory work is reduced in the most significant way. So, in the various studies, and here on ARDS, a cohort study, clinical experiment, you see that the level of support varies between 8 and 14 centimeters of water on average. Very often, the level of water is, there is a titration to have a goal of expiration tidal volume that should be protective. So what we want is a tidal volume between 6 and 8 milliliter per kilogram. But you know that the determinants of tidal volume is not only the level of support, this is why it's more complicated. You also have the compliance of respiratory system and also the intensity of breathing efforts by the patient. So inspiratory support, PEEP, that gives us the maximum. Inspiratory pressure in studies on ARDS, you see it goes between 12 and 20, but I'd like to draw your attention on this work by Fouty in 1997, HJRCCM. It was not meant actually to show these results, but these are patients with inspiratory support, and there was an occlusion in a Servo 900, an older ventilator, and they see that the pressure that is generated in the chest is above the PEEP PS. So one of the messages here would be to limit your maximum inspiratory pressure, and it's the case clearly in most of these studies, but it shouldn't be above 20-25 centimeters of water. It might not be very scientific. It's not based on the major recommendations, but it might be a message of caution. So optimizing NIV also means optimizing the interface, and even if it's hard for me to say so, I think that interface in 2014 is not so much the problem. However, I think that we really need to use an NIV mode. So optimization of NIV means also optimizing the posology, the dosage, the rhythm, the pace, but you need to be slightly Italian here. Why am I saying that? Is because our Italian colleagues have a strategy that is slightly different for the administration of NIV. You see, it's more on a continuous basis, but the message should be maybe we should do more than in a simple COPD decompensation, where in the literature we see that it's 8 hours at least of NIV. Here probably it should be more. It will depend also on the severity, and we have sessions of 1 to 2 hours, sometimes even more, systematically all over the night, each time we can, with some periods of spontaneous breathing of half an hour to 2 hours as a maximum. So we have NIV durations that are much higher than 12 hours every 24 hours. It will depend on the severity of the patient, of course. So how hard to push? I think it's important to have some failure predictive factors. I found 3 at least. The first one is the severity of the patient's conditions and the severity of ARDS in particular. If you look at this work by Armotil in 2013, you see that in the severe ARDS New Berlin definition patients, they are almost all intubated. So I think we can solve the problem of the NIV indication, this subgroup of severe ARDS patients where clearly there's no indication. It's really the red light. So yes, you could still go through, but it would be a risk for the patient. Second predictive factor of failure, the state of shock. Here you see an hemodynamic instability. Here you see the RANA work with patients in shock, and it doesn't work? Yes, okay, yes it does. And the message wants to say that hemodynamic instability is a major contraindication for NIV. And I fully agree, and I'm not the only one. It's a French consensus. The state of shock, the hemodynamic instability is an absolute contraindication for NIV, above all with an ARDS indication. The third predictive factor is oxygenation that is not perfect, and Massimo Antonelli had said so before. Very early on, after 1 hour of NIV, you could have discrimination based upon the PF ratio, patients who would be in a failure NIV situation compared to those with a successful one. And we see the threshold also around 150 in this Anoutil work. If you have NIV with a ratio under 150, then there is a high risk of failure. So I don't want to shock anybody, but in my opinion, as such, it's not an absolute criteria for intubation. I was always told that we should not actually intubate based upon the gas in blood, but I won't intubate either on PF ratio. But NIV in ARDS and optimizing NIV means also knowing when to stop. So when should you stop? When you have the classical criteria of intubation, coma, coma, epilepsy, a state of shock, acidosis. So in literature, you'll see very often it's related to a choice or discretion of the ICU specialist. So what are my criteria? When you have a contraindication for NIV, when you have acute respiratory failure that is persistent under NIV, you have optimized everything you could optimize, but very soon you need to end this and intubate the patient. When the patient is dependent on this NIV that you cannot plug off, so some say above 12 hours, sometimes a little bit more, but we cannot expect to continue in this situation, above all if it's a patient with a moderate or severe ARDS, moderate actually, for sure. And also when the NIV is no longer protective, and here again, I'll show you this work by Hannah. And you see patients with a failure of NIV. They have a tidal volume that is significant, and the predicted tidal volume that is high, probably too high. Maybe NIV was not necessarily with the wrong setting, but they were very severe patients when really patients tend to breathe like this blower. I prefer to go to something that is more invasive. So in conclusion, and it will be really a clear-cut conclusion, ARDS, mild ARDS, yes, you can have NIV, green light. A severe ARDS, then clearly PF under 100 with PEEP with 5 centimeters of water. I think that you don't even have to wonder about it. It's not an NIV indication. And in the middle zone, I think there is some room for a little bit of NIV, as long as there is a monitoring. Maybe the expertise level of the team is important also. But we don't want to take risks for our patients if they were intubated. Thank you very much for your attention.